less effective, and I get really cranky inside because I'm really uncomfortable. So slide them down, get yourself comfortable, okay? If my patient needs or wants a pillow, I'm going to give them one. I'm not going to give them too many unless they feel like without that they're risking something. Same thing with pillow or bolster under their knees. If they want to bend their knees, that's fine, but if we're going to stay here for a while, sometimes they get a little fatigued, so then I'll bolster them up. Okay. You okay right now? Mm-hmm. Okay, good. So at rest right now, what do you feel?
I feel a little bit of tension right here.
Okay.
Like kind of at the outside side of my jaw, base of tongue. Yeah, that's it.
Do you feel any of that posterior pharyngeal sensation right now?
No, not laying
no.
down.
That's even if you've got nothing in this area, meaning dysfunction, problems, etc., at least while your partner is doing this to you and with you, appreciate where you're feeling the effect. And whether it's a stretch or whatever the effect is, and you guys know anatomy in there, you know what's being touched, so to speak, from an anatomical perspective. And even though you may not have the problem, if you can kind of appreciate how far inside it's possible for you to note the impact, remember that for your patients, okay? So what I'm going to do is put my hands on this part of you. Now come up high, if you will, because the first thing I'm going to do is nothing, which is impossible because as soon as I put my hands on her, something is happening, right? But I'm not going to immediately start doing. Now I'm going to peel my hands away here for a minute. This part of my thumb is what I was talking about with getting that sublingual type of a pinch. I want to be able to pinch there, and that's not necessarily the goal, but by being able to do that, it orients my hands anterior enough so I'm clear of the spine and I can be more lateral to the entire thyroid cartilage, like that. If I come back in through here where I'm only able to pinch with my thumbs, that essentially sets up my hands so if I try to do a lateral wobble, I'm wobbling her spine instead of the larynx. All right? So I'm going to come in. I'm going to do a little bit of a sublingual pinch. I'm going to be in the macro right now. I've got a big, broad piece of real estate that I'm holding on to. Can you all see what you want to see? Can you see where I'm at? Okay? If you look at the directions that my index fingers are pointing, from a starting point right now, that's where I want you to at least start. It's as if I'm taking all of this and we're sort of heading in that direction. Okay? I'm not paying any attention to where we believe the larynx should be or is, right? Meaning it's too high, we need to lower it, or it's too low, we need to raise it. Okay? While I'm not saying those don't have merit at all, right now we're simply taking hold of the bony structure, the cartilage structure, the soft tissue structure, the skin, her perception and her awareness, and I'm just taking everything, we're sort of heading up in that direction there. Okay? So, now, what you can't all hear is a lot of the little noises that are happening. Okay, there's a couple just acknowledgments, type of things, right? And as soon as I catch a nonverbal like that, I'll say, "What do you feel?"
It kind of makes me feel like I have to swallow.
Okay, it kind of. I don't know if you can hear her. Okay, it kind of makes me feel like I have to swallow. Is that familiar?
Yes.
Yeah. In what way? When do you feel that?
Yeah, I mean, I think I feel that when there's that tightness at the base of my tongue. Okay. I really feel it when I'm talking.
And you feel it right now?
Mm-hmm.
Yeah, the need to swallow or the whole bigger picture?
The whole bigger picture.
Yeah. Now, as she's talking, it's almost like you can see her eyes searching inside. I'm reading into her a little bit, but I'm also jellyfishing. And by the way, there is a SpongeBob jellyfishing. They use SpongeBob in that, I've been reminded. So I didn't invent the word by any means. Okay. But I'm jellyfishing around.
It's more on that side. I feel it more.
On the right? You mean right there?
Yeah.
Yeah. Okay, so I'm looking for frozen chicken. I'm looking for that thing that scratches the itch in my brain to say, find her fascial restriction. But I'm looking for the thing that she identifies with. Okay? I'm looking for the little crud pocket in there.
Yeah. It almost makes me have to cough.
Is that a familiar feeling?
Oof. That's a little much.
Okay, you want me to back off?
Yeah.
Yeah. Is the feeling of needing to cough? I was doing a little bit more of a hyoid depression right there at that point, where she's, oh, that's too much, right? It's hard when you're watching through the camera because it almost looks like my hands aren't doing a whole lot.
They're doing a lot.
They're doing a lot.
You can see her chin trembling.
Yeah, jellyfishing can be very, very subtle as we look and we seek. Now, help me get in touch with that feeling that brought you up here.
Okay. Right there. When you do that, it's like right on the edge of almost being too much, but it's a pretty good, like that tightness at the back of my tongue is definitely happening.
Okay, so I'm replicating your sensation, but does it feel like you'd prefer if I did less? A less aggressive stretch?
No.
Would you like more?
I don't think I need more. I think this
You don't
is
think
good.
you need? Okay, so I'm playing at a good line right now, right? Now, you're not locked into this. If at any moment you want more or less or different, or you want me to stop, say so, and I'll do it. Okay. Now, honestly, I don't quite know what it is I'm doing to give her that feeling, which really irritates me. Really, it's right. You know, I'm working from 30 years of doing this, and I expect to feel, quote unquote, it. But I'm not sure what it is that I'm doing. But am I doing a good job right now?
When you push this way,
Yeah.
I like feel it more.
Okay. I think that need to pat myself on the back is so strong that I want to know what it is that I'm doing. But yet, I've learned just to allow her to drive this. Okay. I may get a little nosy and say, "You mean that?"
Yeah.
Okay. So I thought it could be that, but you got a big old snot pocket right there, right over on that left side.
Yeah, I mean, I feel that too.
Is it familiar or relevant?
Yeah. It's
Okay.
interesting. I feel like that side is more like the posterior pharyngeal wall, and this side is the base of tongue.
Got it. Snot pockets, posterior pharyngeal. The interesting piece is, and I think it's healthy as a clinician to get our egos put back down where they belong sometimes, because a lot of times I'll poke at what I think is it, right? The thing, the doorbell. And they'll say, "No, I just don't feel anything there." And I really think that that's useful to keep my ego in check, because no matter how much I know and how much I've trained, I can't know what they're feeling until I ask them. Right there. Is that part of it? Mm-hmm. Yeah. Now, if you notice from where you're sitting, watching the video or in person, this is kind of like watching paint dry, isn't it? Right? From afar, it doesn't look like much is happening, because my hands aren't moving in gross fashions, right?
There's a spot you got that makes my chin quiver. It's weird.
Okay. Is that familiar?
No.
No. Is it something you want me to stay away from?
Yes.
Okay. Yeah, then tell me when I get there, okay? A lot of times it's like, no, it's just really weird. I don't care if you do it, but... So, does this feel right now?
It's so strange. I mean, it's okay. It's just weird.
So right now, does it feel like something that what I'm doing right now is potentially helpful?
Yes. I think it's moved a little forward. When your hands were a little further back, I got
So you want me
more.
back there more?
Yeah.
Yeah. And all I did was I was more forward here. I just allowed my hands to roll back a little bit. And it's almost like I'm behind the SCMs. I'm behind the thyroid cartilage a little bit. I'm in that space between the spine and the thyroid cartilage, if you can imagine that. We're going there tomorrow in a little bit more detail. Is this something that feels like it might be a useful stretch?
Yes.
You want me to hang out here? Mm-hmm. Good. So tell me if you want me to stop or change anything. So what am I going to do? You okay? Mm-hmm. Yep, we're getting some. Now I can see the chin quiver, right? You're okay with that?
Yeah, it's okay. It's just weird.
It's a weird, aberrant type thing, and as long as it's just like amusing but not noxious or scary, then we'll just stick with it. Could you come up with a reason why it's happening? We all could. We could make something up, right? It could sound science-y. It could sound stupid. Ultimately, we can't own it, right?
What you often is science-y or stupid.
Ultimately, if she's okay with it, I'm going to hang with it. Because sometimes what wasn't familiar, after she's allowed to put the context straight, sometimes there is a recollection or a connection to it. If I give them time to process and feel and maybe remember a little bit. Sometimes it's just a weird thing that happens. Now again, watching this work is like watching paint dry often. Okay? Except hopefully to the two of us. It should be a dynamic event. The jellyfishing, it's not, I'm not purposefully jellyfishing, meaning I'm not purposefully moving, but I'm allowing myself to adapt to any changes that happen in her feeling, her sensation, the way she's holding herself. I used to think that was the fascia releasing as we melted and moved, right? And now, I don't know what it is. Maybe it's just a reduction in sympathetic dominance. It's allowing a relaxation response. It could be all sorts of things. Who cares? If it feels useful, let's stay with it. Does this feel useful? You want me to get back into that spot?
Oh, yeah.
Yeah. Can you do me a favor? Would you mind going to that vocal range that you did when you were sitting?
I'll try.
Okay. Yeah.
It's harder to do. It's a lot harder to do.
Is that a familiar difficulty?
Yeah.
Yeah. No matter what they say to me, I'll turn it into a question. I always turn it around. And it's about getting to yes. I get 100 no's in a row sometimes until you get to yes. So what initially used to be a very passive modality can become a very active modality where we incorporate movement or function within the stretch itself. Okay. Since they're starting to nod off watching the paint dry. Okay, so when you're ready, take your time. You can slowly sit up, but you don't have to jump right up. Because sometimes people are a little like woozy or dizzy from that, right? You might say, well, that was carotid pressure. It could be vagal. It could be autonomic tone changes. It could be, who the heck knows, right? Wow. Good wow?
Yeah, good wow.
Okay, good wow. Good wow. Good wow.
Yeah, very good wow.
Okay. All right. Anything you want to share about that?
Yeah. I'm a little woozy.
Yep. You okay with that?
Yeah, it's fine. Yeah, there's a lot less tension. I still feel it at like the sides of the base of my tongue, but the back of my pharyngeal wall feels much, much better. Yeah.
So if I was actually doing intervention with my patient, I'd sit her up well before it was time to stop, right? I'd let her process, I'd let her feel, maybe go into those places, whether it's with voice or swallowing or song, to test it out. She said, now that feels better, but now it's over here. Good, let's lay back down and let's have another look at it, right? Let's try it again. That's the way my interventions are modeled, but you're probably going to take her from here and go to inserting all the other interventions, strategies that you do, okay? Do you have any questions, comments?
Is that the only position, is being behind her, that you can do that?
No, we're going to do it in sitting. I prefer being behind. A lot of people who do laryngeal manipulation do it from the side or the front. It all works. Okay, we'll talk about that either today or tomorrow when we get to the sitting work, okay? It's just my favorite because it's my bias. It's what I've done for 30 years, and I like it, right?
Because in reality, our patients are probably, the head of the bed is against a wall.
Oh, that's so hard to work in a hospital bed, yeah. If you can get them in the wheelchair, it's so much better. If you've got a mild tilt in space type of feature, that's really ideal. You get them out of gravity a little bit so they're not fighting you, but then sometimes function happens in that fighting position or that gravity position where it's useful to work with them in sitting as well as supine. Okay?
I'm just kind of curious, if you were to do the glides now, how it feels. So if you're up for it.
Wait, say that.
Do the glides.
Do the glides.
Okay. Yeah, they feel easier.
Feels easier.
They're
Good.
louder.
It sounds louder.
Yeah.
Clearer. Yeah.
Again, lots of factors that influence that beyond what I did with my hands. We must understand that. But yet, if she's getting up right now and it sounds louder and sounds easier and feels easier, that's brain food right there to say, all right, I have potential to change. And I think that's huge. It's a huge part of what we do for a living that goes, I think, without enough credit. The possibility that we insert into their brain that change is possible. Anyone else? No? All right. Anything else you want to say? Okay, good. Thank you very much. All right. So I am going to ask you to do this one in laying down. And whether the timing is we do the sitting one this afternoon or first thing tomorrow morning, we're going to do one follow-up in sitting after this. Okay? All right. Let's give it a go.